everyone, and welcome to the 10th episode of Transform 360. I am your host, Sabah Arshad, a pharmacist, mental health advocate, and your guide to personalized well-being. Before we dive in today, I want to take a moment to say thank you. Reaching this milestone is truly special, and it would not have been possible without your support and feedback. Whether you have been here with us since episode 1 or have just joined us, I am grateful to have you on this journey. And what better way to celebrate our 10th episode than diving into the evolution of care from a genetic counselor to pharmacist to a founder with Jeri Nichols, whose journey perfectly captures transformation in healthcare. Jeri is a trailblazing pharmacogenomics expert with over 2 decades of experience as a pharmacist and a genetic counselor to revolutionize personalized medicine. Jeri founded GenePharmer LLC in 2021, consulting practice that empowers patients with safer, more effective medication regimens, often reducing reliance on unnecessary medication. Throughout her career, her individualized approach, rooted in listening to patients and leveraging genetic insights, has improved countless lives across private practices, medical centers, genetics labs, and community pharmacies. As a passionate educator, she advances from for students and presentations at professional healthcare meetings. We invite patients and providers to explore pharmacogenomics at genefarmer.com, cultivating healthier futures and one genome at a time. Welcome, Jeri. I am so honored to have you here.
And thank you, Saba. Thank you for the wonderful introduction. And I'm very honored to get to be your 10th podcast. So very exciting to join you today and get to see you again.
Likewise, yeah. And I just wanted to thank you. Jeri is my go-to person. Whenever I'm seeking any kind of support, Jeri is one of them. So I'm really grateful to have you in my life. Let's start at the beginning, Jeri. You have had such a unique journey from falling in love with the squares in high school to founding GenePharmer. Looking back, was there a moment of clarity when you realized that pharmacy and genetics weren't two separate callings, but one?
I can't say that there was exactly a moment. I think it was more of a process over time. So in doing genetic counseling, I was working in high risk obstetrics, and that meant that I was, working with families that had some concern about a pregnancy. Fortunately, most of the time, there were good outcomes, healthy babies. But part of the process in talking with and working with those families, I would take an exposure history. So, getting what kind of medications the mom might have taken during the pregnancy, alcohol, tobacco, any illicit drugs. And so this theme of medications, came up over and over again. And it was something that we were taught a little bit about in genetic counseling programs, where you talk about medications as far as their teratogenic potential. And I also worked with an MFM when we were in the Houston area, Dr. Thomas Rowe, who was just a fabulous maternal fetal medicine doctor. And there was a pharmacist in like the next building over that he frequently called on when he had questions about things with patients and prescribing. And so I thought that was a really unique relationship that they had. And then when we moved back to Missouri, where my husband and I are from, the university here had just started a satellite pharmacy training program. And so like this theme of pharmacy and medications just kind of kept coming up over and over again. And ultimately, several things kind of led me to deciding to change careers and go to pharmacy school. But when I entered pharmacy school, I had this thought that I wanted to combine my genetics background with pharmacy. It was 2010 when I started pharmacy school, and I think that CPIC was created in 2009. So CPIC, of course, being the Clinical Pharmacogenomics Implementation Consortium. So there weren't a lot of clinical guidelines that were available yet for pharmacogenomics. And I frequently talked to like preceptors and things during pharmacy school that I wanted to do something in pharmacogenomics. And everybody was like, oh yeah, that sounds really neat. Good luck. Because it was new, it wasn't, being taught in pharmacy school at that time. And so it was one of those things that nobody really knew how to like point me in a direction. And then I just kind of fell into retail pharmacy after several years, decided I was going to look into pharmacogenomics again, and then ended up creating my own business in 2020. And it's worked out well. The theme of genetics and pharmacy have come up a lot over the years, and I find a lot of overlap between them. And part of that, I think, comes from the fact that like genetics affects every single system of the body. There's a genetic disorder for every different organ system. And with pharmacy, it's kind of a similar thing in terms of you've got medications to treat conditions that affect like every organ system, but also your genetics definitely play a role in how well you respond to a medication or if you respond to a medication.
That's amazing. Thanks for sharing that incredible journey with us, Jerry. And you have spent a decade, with counseling families and working in community pharmacies. How have those deeply human experiences shaped the way you approach patients nowadays, and especially when you have to combine the genetic data to guide medication choices?
So I think one of the things that I definitely learned to appreciate, especially having done the genetic counseling, is really listening to patients and letting them tell their story. And sometimes it may seem to providers like their story doesn't really have to do with whatever the situation is that you're seeing them for, but it can actually be very important. And when doing, genetic counseling, I really had this nice advantage, I guess, over what a lot of practitioners have in that I could spend an hour, sometimes longer if needed, with a woman or a couple or a family, just kind of talking about the genetic concerns and the family history and the testing that might be available. And that's something that I really enjoy doing now that I have the pharmacogenomics practice also, is being able to spend time with patients and kind of get to know them and figure out the best way that I can help them. There's unfortunately so much about our healthcare system, including retail pharmacy, even though pharmacists are very accessible, you can get, kind of free consultations, is the time factor.
That's true. And that also hinders a lot of other stuff. And clearly, your work isn't just in the clinical portion, but it's deeply personal. My next question would be, to a lot of people who are listening to us, pharmacogenomics might be a pretty technical term, but at its core, how would you explain pharmacogenomics to patients in a way that makes them feel seen, heard, and understood?
Yeah, so again, part of that is just listening and letting people tell their story. Sometimes you can understand where medication issues have arisen based on the order that medications were prescribed in. That something is maybe just treating a side effect of something else. And then trying to use simpler layperson language versus medical language.
Hmm.
It was something that was definitely drilled into us in grad school, when doing genetic counseling, was talking in terms that patients could understand and using a lot of visual aids, things to help patients understand about genetics. In some ways, I think it's a little bit easier now than when I started in my career in healthcare because genetics is in the news. It's used more in school. It's taught more in school. My kids learn things in high school that I didn't learn until late in college. Or possibly grad school with respect to genetics. But still, I find myself sometimes, using more medical terms, words like pharmacogenomics, that you really just have to break down and explain that, like, our genetic makeup, we're all different. We don't look the same. We may resemble our family members more than our friends, but our genetics is like the blueprint that makes us. And it's what makes us unique. And those genetics are part of the reason that for some people, a given medication may work really well. And for someone else, it may cause them, horrible side effects. So it's just kind of trying to give relatable terminology, I guess.
Makes sense. That makes sense. And I would really love to get your perspective on two things. The first would be we have other ancestry tests as well. That is what I have seen. People seem very confused between medical genetics and part that where we talk about just medications. How do you approach that scenario?
Yeah, that's a really good question. Uh, is one of those things that I think in part goes to informed consent. That's the genetic counselor in me that I'm very big on. If you're going to do a test, you need to provide informed consent to the patient, which means you're telling them what the test can and can't tell them, the risks, the benefits, the limitations. And so part of that is explaining that a genetic test is not a genetic test. There are certainly tests like whole genome sequencing, where the purpose may be trying to find a gene that's causing an inherited cancer syndrome or a muscular dystrophy or, something like that, like a genetic condition. And then you have other tests, like you said, ancestry type tests, where you're just trying to maybe find relatives that you didn't know about or where your ancestors originated from. And then the pharmacogenomic testing, it doesn't really tell you anything about your ancestry per se. for the most part, tell you about your risk for health conditions, although there are a few exceptions, and that is part of what I talk to patients about because there are some genes on the panels like factor 5 and factor 2 that if you have variants in those, it can increase your risk of blood clots. So that does end up being a health risk. And the reason that those genes are on the panel is because they don't exactly metabolize drugs, they're not targets of drugs. But those two genes, because they increase the risk of blood clotting, and then there are drugs that increase the risk of blood clotting, so the two of those together can become problematic. And then you have some other genes like sometimes ApoE is on a lab report, and that could indicate an increased risk of Alzheimer's, in addition to maybe how you respond to cholesterol medication. So I do try to forewarn patients about those sort of secondary findings.
Perfect. Thanks for explaining that. And since we're talking about ApoE, I would love to get your perspective on ApoE and MTHFR. Now, what I feel, it has just become a buzzword that people would use on social media. So, what are your views on it? Because I have met other genetic counselors and I know their perspective, but I would appreciate yours.
Yeah. So just briefly on the ApoE, the lab that I use has kind of taken that off of the report, which I appreciate because I didn't find it terribly helpful for cholesterol medication. And occasionally it can create some anxiety in somebody if they have an ApoE4 variant, even though having that variant doesn't mean you're going to develop Alzheimer's. It just means your risk is higher over your lifetime than someone that doesn't have ApoE4. And so maybe you want to make lifestyle changes or something related to that. And then as far as MTHFR, it's on, I think, pretty much every pharmacogenomic test that I have seen. And what you exactly do with MTHFR related to most medications is pretty unclear at this point. There's been some talk, about potentially a CPIC guideline, addressing MTHFR. And you're right, there's lots of hype, there's information everywhere. If you were to Google MTHFR, you're going to find that it causes absolutely everything under the sun.
That's true.
And it's been kind of a love-hate relationship, I will say, that I've had with MTHFR for a few decades now. Because when I was doing genetic counseling and very early in my career, I started coming across a lot of MTHFR test results on my prenatal patients. And the reason for this is that it had been added to a thrombophilia panel. So a blood test panel that was looking to see if a woman had the factor V Leiden, prothrombin mutations, like protein S or protein C deficiency, so various things that could lead potentially to blood clots. And the reason that the thrombophilia panel was created was that there was some data saying, okay, if you have a predisposition to blood clots, you're more likely to have miscarriage or stillbirths or small babies that are small for gestational age. And MTHFR kind of got thrown on there because there is a condition called homocystinuria, and where individuals have high levels of homocysteine in their urine and their blood, and to the point that they have very early cardiovascular disease, blood clots, various other things. And this can happen because of mutations in a gene called CBS, and it can happen from mutations in MTHFR. But the people that have homocystinuria have variants in MTHFR that are different than the common ones that the pharmacogenomic tests are testing for, and different than the common ones that are on the thrombophilia panel. So anyway, I ended up doing lots of counseling for patients because MTHFR, those common variants truly are common. I've rarely actually had somebody have an MTHFR study done where they didn't have at least one variant, whether it was the C677, severe is not really the right word, but the more impactful variant than the A1298C, I think is the other number. It's less impactful. Both of them reduce how much of the MTHFR enzyme your body produces, and so they can affect how you process folate. And that's important because folate provides a methyl group, which then is used in how your body produces DNA and proteins. And it's connected to so many things. That one carbon cycle is also connected to how the body creates serotonin and dopamine. So, the neurotransmitters that you need. It also downstream affects the ability to produce glutathione. So how well you can deal with oxidative stress and kind of clear things from your body. And so I do think that there truly is something to MTHFR because of how connected it is. Kind of like if you think of an old style watch or a clock that has all those gears, that are connected to each other. And so if you have one gear that's kind of gummed up and not turning right, it
Yeah,
affects all of the rest of the gears.
makes sense.
There is definitely data that if you have MTHFR variants and you have elevated homocysteine that in your blood, then you're going to have an increased risk of cardiovascular disease. There is also evidence that if the mother has two copies in particular of the C677T, and if the fetus has those as well, like that's the highest risk of the baby having a neural tube defect. And that's part of the reason that our food supply was supplemented with folate.
Yeah.
Folic acid, was put into cereals and grains and breads and things back in, I think, the late 90s. And that has reduced the incidence of babies being born with spina bifida and anencephaly. So there's definitely something to MTHFR. But again, it's been explained for everything: cancer, IBS, depression, eczema, gut issues,
Yeah,
everything.
anything.
And for years, I will tell you that honestly, I thought MTHFR was overhyped, that it was being blamed for a lot. And I do think that that's how most people in the genetics community feel about MTHFR. But when I started looking into pharmacogenomics, I saw it coming up a little bit more. And I found American Psychiatric Association have a guideline for like treating depression. And in their guideline, they mention supplementing with folic acid as like a augmenting thing that you can do along with an SSRI. And they talk about how there is data that individuals who have low folate
Mm-hmm.
don't respond well, like to fluoxetine, for example, an SSRI. But if you give them folate in addition to the fluoxetine, then you get a much greater antidepressant response, which kind of makes sense because if you're feeding that pathway, you can get more neurotransmitters being produced. Nowhere does it mention MTHFR at all in that guideline. But I suspect that if you looked at the people who had low folate, that's probably the individuals who would have those MTHF. So I do think that there is something to it. Our diets are unfortunately not great in America. And even with the folate supplementation, it still has to be converted using MTHFR. And so for people who have variants, the folate that's in cereals and grains maybe isn't that beneficial. And so you may truly need methylfolate so that you just kind of bypass the fact that you have less of that enzyme.
Mm-hmm. I truly appreciate your insight, and that was really powerful how you talked about um, how this thing started from MTHFR. So that was a really good. I learned something new. I didn't know about MTHFR being used back in the genetic counseling world. Yes, so I appreciate that insight.
It's interesting because a lot of like ACOGs, the American College of Obstetrics and Gynecology,
Uh-huh.
and ACMG, the American College of Medical Genetics, they both recommend against like routine MTHFR testing. They recommend against testing it on thrombophilia panels, but it's one of those things that I think once it got on the panel a couple decades ago, it's just kind of stuck.
Yeah.
It really hasn't come off.
That's true. Once the patient is signing the informed consent form, and once everything is done, it's always good to let them know the expectations are met. And yeah, because I've seen a lot of standalone tests that are just offering MTHFR for the same price of what a full panel for pharmacogenomics would be offered.
Yeah, I've seen that too, and I could not justify spending a couple $100 to test just for MTHFR or just for a couple of methylation genes. Yeah.
That's true. That's true. Another question would be, since you started your company, and not just as a clinician but also as an entrepreneur, what's the most surprising lesson on that journey, whether it's about our healthcare system, the science, or even yourself?
Hmm. There's probably been a couple of surprising things. One is just seeing that like my initial vision for the consulting company has gone in a slightly different direction. So, my vision was that I wanted to make pharmacogenomic testing available to people in Missouri because there really doesn't exist a pharmacogenomics program, at least in central Missouri. There are kind of ones in St. Louis and Kansas City at this point, which are both, 2 hours either way down I-70 from where I am. And that was just my thought. All right, I'm going to take this straight to patients, make the testing available to them if they want it. And I have done that. I do see patients in my consulting practice, but then it's kind of morphed into something more because I've done consulting for genetic counselors, for other pharmacists, and then I've been invited to speak speak a fair amount to people, and that wasn't something I ever really envisioned doing, but it is something that I enjoy a lot. So I've spoken with a couple of different professional groups in like Connecticut, in Texas, in Missouri, and even had an opportunity for a webinar that was held this last winter that was international. So it was put on by a group out of like Africa and India, some really amazing pharmacy students who were super interested in pharmacogenomics. And they got different kind of experts from around the world to come to speak with them. And I was very honored to get to do that.
Do that. That's amazing. Thanks for sharing that. And I think there's so much that we keep on learning about it, about ourselves. There are a lot of hidden talents that show up.
Yes. And then I would say the other thing that I also didn't really see coming was adding nutrigenomics into pharmacogenomics. So part of that has come about because of health issues. Like I was diagnosed with Hashimoto's a couple of years ago after this string of like very strange symptoms, and having other family members with issues that took some time to get sorted out and treated, and just kind of seeing how our healthcare system, and it's ironic that I didn't recognize this before as a pharmacist, but how our healthcare system really treats symptoms and throws medications at things and doesn't ask, like, why is this happening? What is the root cause? Is there something deeper that we can address that maybe would prevent somebody from ending up on 20 or 30 medications? Maybe they only need 4 or 5 and some lifestyle changes, or something like that. So that was another surprise that I didn't see that coming, but I've enjoyed it. And I think nutrigenomics and lifestyle genetics fits very nicely with pharmacogenomics.
That's true. I would love for you to give an example for the listeners. They will have a basic understanding of what pharmacogenomics is. Is it any patient interaction or any experience that just stuck with you or you would like to share?
Definitely. I have several examples, and a lot of them I think kind of revolve around treating depression or different forms of mental illness, because for a lot of patients, that ends up being a very long journey where they're trying multiple medications before they get to something that works. In pharmacogenomics, while it's not magic and it's not going to be able to tell you exactly which medicine is going to work for a patient, it's a good tool to have to like guide you where certain meds might be better and other ones you probably want to avoid even trying. And so I think that's where a lot of patients have found success or good answers. And one patient that I think of in particular was this patient who told me that in the past, if they had a bad cough, they might take dextromethorphan, a common, over-the-counter cough medicine. And if they took it, they would normally only take it 1 dose at bedtime to help them sleep. And they would wake up the next morning feeling like groggy and hungover and just kind of not themselves, sort of out of sorts. So that was also part of the reason they only ever took it at bedtime if they needed it. Well, at one point, this patient was put on one of the GLP-1s like Wegovy or Ozempic, and while on that medication, developed a bad cough. So took a dose of dextromethorphan. And after doing that, they said that they felt awful. They felt like shaky, sweaty, their heart was racing. They had restless legs, they had insomnia, ended up going to the ER and felt like they had like serotonin type syndrome. And the ER doc was like, that's not possible, with a single dose of dextromethorphan. Their PCP and their psychiatrist pretty much told them also that's not possible. But it impacted them so much that they did not want to take another dose of dextromethorphan. And then like 6 months later, they were given a medication for depression, an antidepressant. They had kind of a history of depression, and so started this medication. I think it was escitalopram. Took a single dose, and the same thing happened as what happened with the dextromethorphan: the shaking, the sweating, the insomnia, just not feeling good. And again, they were told like, oh yeah, serotonin syndrome's not possible like that. So had really gotten to a point where the doctors were telling them things weren't possible that were happening to them. And they were just really kind of scared to try medication because they'd had this episode with both a prescription medicine and an over-the-counter medication. And so through a friend of a friend, ended up with me doing the pharmacogenomic testing. It came back and said this person was a CYP2D6 poor metabolizer. So CYP2D6 is a common enzyme that metabolizes like 30% of the most commonly prescribed drugs. And so it's a very important enzyme to have in the body. If you're a poor metabolizer, that means that you either don't metabolize, don't make the enzyme, or you make very little. So any medications that are metabolized by CYP2D6, you're going to react differently, potentially strongly or not at all, depending on the medicine. And so dextromethorphan is broken down by CYP2. And if you're a poor metabolizer, the half-life of it goes from like 4 to 6 hours to about 24 hours. So instead of taking a day to get one whole dose out of your body, it takes like 5 days for an entire dose to. So it totally made sense that this patient was saying in the past, I would take it and I'd feel groggy and hungover the next day. Their genotype, their genes kind of explain that. And then the GLP-1s, there's a lot we don't know about those medications right now. But it does seem that they work in the brain, and they probably do promote some serotonin production or something. Plus, a lot of serotonin is made in the gut, which is also where the GLP-1s are working. And so just the combination of the genetics, the reactions, and the medications, to me, it made sense. And for the patient, then they felt very validated. Like, I'm not crazy. I really experienced this, and there is a good explanation for why it happened.
That's true. Thanks for sharing that patient experience. I'm sure a lot of people can relate to it. Just taking one simple medication, and there are a lot of changes that you see in your body. Okay, and just a quick one. I would just love to get, like, we as pharmacists, why there are not a lot of people who are pursuing pharmacogenomics, or as you mentioned, it's not being taught in colleges. Is it because we are uncomfortable, or Mm, we are not given enough opportunities?
I think it's probably a combination of those two things. There's definitely a lot of discomfort with genetics, and that's one thing I've known since I was very young, that it seems for most people, you either love genetics or you hate it. There's not a whole lot of in between.
Okay.
Obviously, I'm one of those people that loves it, and that's always my goal when I go and talk to professional groups or students, is to try to give them stories and things that will help inspire them and make them think that genetics is interesting. So yeah, I think part of it is discomfort, just not feeling like they have enough education on it. And then there are definitely things that have happened over the years where things have been misrepresented or misinterpreted. And so I've come across positions, and I've certainly heard, as you probably have from lots of other pharmacists, where you've got prescribers who don't believe in pharmacogenomics. They think it's like snake oil, it's not real, and I think we have a long way to go to kind of try to re-educate and help people understand like what it really is and what it really can do,
Yeah,
as well as what it can't do.
that's true. Thanks for sharing that, Jerry. And where can listeners go and learn more about your work? Do you talk about certain topics on Facebook, or do you have any platform that you use?
So I do have a website, which is GenePharmer.com. And then I have a Facebook page. I do have both a LinkedIn page for the business and for myself. And so, yeah, I do talk, not as much as I would like, but I try between those platforms to, yeah, kind of put information out there about pharmacogenomics, nutrigenomics, sometimes just healthcare in general.
Yeah, that's true. Thanks for sharing that, Jerry. Now let's lighten it up. Now I will move to a rapid fire questions round, and just answer whatever the first thing that comes to your mind. Let's start. Tea or coffee, Jerry?
Tea, without a doubt. I have never been a coffee drinker.
Okay. Okay. A wellness tip that you actually live by.
I would say one that I have taken up in the last year um, is in relation to vitamin D. So, I just assumed vitamin D was one of those things that I had plenty of, and my levels were actually low. So, I do recommend everybody get tested for your vitamin D level, because it's important not just for your bones, but it's important for your brain, for your mood, for thyroid function, lots of things. And so, I make an effort to both get more sunlight, but also more supplementation with vitamin D.
Perfect. One genetics or pharmacogenomic myth that drives you crazy.
Say that again, sorry.
It's okay. One genetics or pharmacogenomics myth that drives you crazy.
Gosh, there's probably several. I don't know. I think it's probably the MTHFR thing, because it's just so misunderstood that people tend to, kind of like I said, people either love or hate genetics. With MTHFR, I think people either attribute everything to it, or they completely dismiss MTHFR. And the truth is somewhere in between.
That's true. That's true. One thing people are always surprised to learn about you.
Probably just that I have two different professional degrees. Um, because most people either meet me under the setting of a pharmacist or the setting of a genetic counselor. Nowadays, it's more the pharmacist.
Yeah,
But I think people are often surprised to see that I have like both of those backgrounds and then that I put them together.
that's perfect. And now you also have experience of being in a specialty pharmacy, so you have a very diverse clinical experience as well. What is one thing that you would like people to take away from today's conversation?
I think just take away that pharmacogenomics is not something scary. And it's something that could be very beneficial for helping you not just with what medications you might be on today, but it could help you in the future, knowing that certain medicines might be likely to work for you or they might be medications that you want to avoid.
And what is last question? What is one morning ritual that you can't miss?
That I can't miss. That's a tough one, Saba.
God, okay.
At one point in time, I would have said breakfast
Okay. Yeah.
because I grew up eating cereal and breakfast. Like I wake up hungry, breakfast was my thing, and in particular cereal. But with the Hashimoto's, I went gluten free. I don't eat cereal anymore, even though like Cheerios, and there are some things that are gluten free.
Hmm.
I've switched to having actually sunflowers and pistachios and cashews for breakfast. Um, but I can't say that I won't miss that because I've found some value in fasting sometimes too. So sometimes missing breakfast. It might actually be my hair because I with curly hair I can't sleep on it and wake up and have it look nice. So if I'm going to be seen by other people, I
Yeah.
pretty much have to do my hair.
Yeah.
Yeah.
Makes sense. Okay. Thank you so much for sharing your story today. Everything, I appreciate all your perspectives. It really enjoyed my conversation with you, Jerry. And to all of our listeners, thank you for joining us. Take care of your whole self, your body, your brain, and your heart. Science is powerful, but so is compassion. Stay curious, stay kind, and don't be afraid to ask questions, even the weird ones. That's where the magic happens. And until next time, stay balanced. And thank you so much, Jerry. Thank you so very much for your time. And I have to have you back for another session in our second season. Thank you so much.
Thank you, Saba. It was very enjoyable. I appreciate it.